of immunohistochemistry, we were able to find a big rate of positive pelvic nodes. What about guidelines? In the United States, since 2016, NCCN guidelines introduce the role of sentinel node as an acceptable method for staging in uterine confined tumor endometrial cancer. What we mean with uterine confined? We mean uterine confined all the tumor in which we have a negative radiological staging. I mean PET-CT, CT, whole abdomen CT, or MRI. In all these cases, sentinel node can be introduced at the staging disease, staging approach. Since this year, from 2000, at the end of 2020, the ESGO, ESTRO, ESP guidelines recommend the use of sentinel node not only in low grade or low risk endometrial cancer, but also in high, intermediate, and high risk. This is the question. All the previous paper about the role of sentinel node are mainly in low risk endometrial cancer, in which we know, thanks to the old study, that the role of lymphadenectomy is not associated with an increased overall survival or progression-free survival. These are the two relevant paper. I mean the study by the Italian group of Luigi Benetti Manici and the Aztec trial, which identify no evidence of benefit in terms of overall survival or recurrence-free survival for pelvic lymphadenectomy in low risk. But also in these cases, we have a risk of nodal spread of almost 5%. So we need to do a staging. We know that is a low risk or high risk only after dissection of the node. This is a very well done paper, a meta-analysis in which this is a comparison between sentinel node mapping and full pelvic lymphadenectomy, in which it seems that sentinel node is superior to the lymphadenectomy in detecting low volume metastasis, thanks to the fact that we can use the ultra staging. I want to mention the FIRES trial. FIRES trial is a keystone of this approach, published 3 years ago by the group of Chicago, in which all cases in all cases sentinel node dissection was performed, and after full pelvic, and in half of patients also aortic lymphadenectomy. They reach a sensitivity of 97.2% and a negative predictive value of 99.6%. It means that if I have a node, sentinel node, a negative sentinel node, I cannot find any positive non-sentinel node in the patients. So reducing the morbidity, improving the detection of low volume metastasis in order to stratify patients for adjuvant therapy. What about other publication? This is another cornerstone study published some years ago in 2016. Is between the two main cancer centers in the United States. I mean Mayo Clinic and Memorial Sloan Kettering Cancer Center, added by the MD Anderson. Probably these three centers represent the best of American cancer center. In these two centers, for the last 10 years, they have a totally different approach in order to stage patients with uterine confined endometrial cancer. In the Rochester Mayo Clinic approach, they do hysterectomy, frozen section, and lymphadenectomy, tailored lymphadenectomy according to frozen section. I mean, no lymphadenectomy in low risk, lymphadenectomy in medium and high risk. In the New York experience, Memorial Sloan Cancer Center, every patient staged by sentinel node. They compare the two populations. They observe no differences in terms of overall disease-free survival. This means that sentinel node can be considered a good alternative to the pelvic lymphadenectomy, with a consequent reduction of morbidity associated to the pelvic lymphadenectomy. We reproduce the same study in Italy, comparing our data with the data from University of Monza, and we observed the same results. No differences between patients treated by sentinel node compared to patients approached with full pelvic lymphadenectomy. Again, a retrospective validation of this approach in these patients. What is really the additional rule of ultrastaging? Thanks to the ultrastaging, we are able to detect in 5% of patients with positive node. So in case of no ultrastaging and no sentinel mapping, we can lose these patients because probably these patients that are not candidated to adjuvant treatment can be relapsed with a consequent reduction of overall survival. Another relevant data is the rule of skip metastasis. Why pelvic lymphadenectomy in case of, for example, no mapping? At the beginning of this century, we remember that in high-grade cervical endometrial cancer patients, we have 2% of positive aortic nodes with negative nodes in the pelvis. And this means that for endometrial cancer, we can have a skip metastasis, skipping the pelvic nodes. What they do in the Mayo Clinic, they review all the nodes, all the pelvic nodes in patients with only positive aortic nodes. They review all the nodes by ultrastaging, and they found that in all cases with positive aortic nodes, there were low volume metastasis in the pelvic nodes. So again, the additional rule of enhanced pathological analysis of the lymph nodes. This is the algorithm proposed in order to reduce the risk of false negative. It means that we, first of all, and this is what we will do in few minutes for these patients, peritoneal and serosal evaluation and washing, retroperitoneal pelvic evaluation. If we have no bulky node, no suspected node, we inject the cervic stroma, and with the tracer, we use endogenous green tracer. And in case of mapping, we remove only the first node draining from the cervical tissue. And in case of no mapping, we can do reinjection and at least site-specific lymphadenectomy in case of no mapping. Why we use endogenous green? Because it's well demonstrated that endogenous green is the best tracer that we have in the OR. The alternative is the combination, the blue dye and the technetium, but we need nuclear medicine in our OR. So the endogenous green is the preferred, is the recommended tracer for these patients, with an increasing of bilateral detection. Where we have to inject for endometrial cancer, this is a very well done study, Italian study, that randomized hysteroscopic versus cervical injection, and they showed that this study supports and confirms the rule of cervical injection instead of hysteroscopic injection, because of the former allows better identification of sentinel nodes, and the little high rate of aortic diffusion of the tracer is not significant. Another relevant tips is in case of no mapping after first injection, try to reinject the cervical stroma. Normally we inject the stroma at hour 3 and 9, a total of 4 milliliters, 2 milliliters deep and 2 milliliters superficial. In case of reinjection, we do only the deep injection in the side in which we didn't identify the mapping. In this paper, they found that thanks to the reinjection, they can improve the rate of bilateral from 78 to 94% of patients. So only in 5% of cases, they show no bilateral dissection. Which can be the reasons of no mapping? We do a retrospective study, and we identify that the risk of no side mapping are the histological type, I mean non-endometrioid versus endometrioid, the presence of lymphovascular space involvement, and the bulky nodes. But if you consider that all these three characteristics are all associated with the risk of nodal diffusion, because if I have a nodal metastasis, the node doesn't function, so there is no draining, and in case of no mapping, I should perform a pelvic level 1 lymphadenectomy. I mean the resection of the external iliac, internal iliac, and obturator nodes, because probably in this case I will found some positive nodes. As I told you before, after the beginning, the question was if the sentinel node is adequate and safe also in high risk. We demonstrated in this paper, published 3 years ago, that in high risk and group following the ESMO-ESGO-ESTRO classification 2016, there were no differences between the sentinel node approach and pelvic lymphadenectomy. Again, a retrospective validation of this approach in these patients. If you consider the type of patients normally affected by endometrial cancer, old patients, obese patients, the possibility to reduce the morbidity associated with the lymphadenectomy with an improvement thanks to the ultrastaging in the detection rate of low volume metastasis, the result is that it is recommended in all patients with the uterine disease is apparently confined in the myometrium. Also from the MD Anderson Cancer Center, we have a retrospective validation of this approach in high risk. And this is last week, it was published this paper in the International Journal of Gynecological Cancer, in which they compare the patients with stage 3C, I mean patients with positive node, comparing patients who detect the metastasis only by sentinel node, and the group of patients that was submitted to pelvic lymphadenectomy. At the end, no differences in terms of survival. Again, also in case of positivity, the removal of the only positive nodes doesn't affect the prognosis. Again, in the uterine confined endometrial cancer, there is no prognostic rule, no therapeutic rule of lymphadenectomy. What about peri-operative surgical outcomes? For sure, we know that the addiction of sentinel node dissection doesn't affect the postoperative outcomes. And in this study from the United States by Ivan Casarin in the Mayo Clinic, sentinel node biopsy was not associated with worse morbidity if compared with only hysterectomy. So no addiction of morbidity, but staging all the patients. What is the real significance of this new entity? I mean, low volume metastasis. This is the challenge of this time. We don't know if it's different to have an ITC, a micrometastasis. We consider micro as macrometastasis. We treat all patients with micro and micro with the same way. I mean chemotherapy and radiotherapy, adjuvant chemo and radiotherapy. And we consider ITC as negative. But we still wait definitive data about this. We know that in case of treatment, patients with negative, with ITC or with micrometastasis has the same prognosis, very better than the macrometastasis. So the amount of the dimension of the metastasis is associated with the prognosis. And in other study, we saw that the risk of the reason of treating patients can be adopted only in micro and macrometastatic tissue. What about ETC? ETC are the real challenge because we know that the presence of low volume metastasis is associated with worse prognosis. In particular, take care to consider patients with ITC with potential positive. So prolong the follow-up period, and because we saw that at the beginning, in the first 5 years, we have no differences between progression-free survival and overall survival in ITC or negative node. But after 5 or 6 years from the diagnosis, without adjuvant chemotherapy, because we consider ITC negative, we start to find some relapse in the ITC group. So again, probably the presence of tumor cells in the node, also smaller than 0.2 millimeter, can be associated with an high risk of recurrence. And this paper was published 2 days ago in Gynecological Oncology by the group of the Memorial Sloan Kettering Cancer Center. They demonstrated that ITC in sentinel node should be noted at N0I. Is different from N0, and is not for the way to treat patients only in case of ITC, but we have to have more data about the low group of patients with ITC and none other risk of in the tumor that they don't perform adjuvant chemotherapy. Last 2 slides before the live surgery. What's new about histopathology? There is another method apart from ultrastaging. This is the OSNA approach. OSNA is a molecular approach that combines the amplification in order to identify the copies of the mRNA of the cytokeratin 19. According to the number of the copies, we have negative, ITC, positive, positive macrometastasis. Nowadays, we are performing a study in Italy. It's a multi-center study in which all patients submitted to sentinel node dissection. The node is divided in 4 or 6 parts, considering the dimension, and these parts are alternatively sent to the 2 methods, I mean ultrastaging or OSNA, in order to compare these 2 approaches. This is a method really largely used in breast cancer. We are doing now a study in order to confirm this approach also in endometrial cancer. And with these slides, I stop my lecture, and thank you very much for your attention. Write to the chat, and I will be very confident with the answering.